Thanks, everyone. Could we start by me just trying to get a sense of who we have in the room? Any Amnesty International members in the room?
Yes.
At least one? Okay. Hopefully by the end of this hour and a half or so, you'll be so excited you'll want to join, and we've made it very easy for you by putting a pamphlet on the table in front of you. Medical folks, hands in the air, great. And what do other folks do? Students here, what kinds of things what are you studying?
Bio.
Bio.
And music.
And music, excellent. Other folks? Yep. Psychology, yeah?
Social work.
Social work, super. And what drew you here? What's interesting about the title or the topic? Yeah, please.
Human rights.
Human rights. Okay.
Maternal mortality.
Maternal mortality, great. And others of you were forced to be here by somebody.
The poster. Too.
Coerced. The poster?
Yeah, as soon as you see like a belly, you.
Right.
Well, I think for nursing, global health issues are becoming tremendous, and our focus needs to be there. So, unfortunately, we couldn't bring our students that are working, but
yep.
we can pass it down to them.
Yeah, yeah, yeah. Believe me, I know. My partner is a family doctor. Wanted to come, but medical folks are always very busy. So, well, great. So, as Dana said, I'm Jason, and this is the topic: maternal mortality and human rights. And I'm going to try to make this kind of interactive throughout. So please, raise your hand, and I'll be pausing periodically just to solicit questions. Here's the outline: human rights, maternal mortality, and then maternal mortality and human rights. So, by the end of this session, I should have told you a bit about the history of Amnesty International, background information on the right to health, basics about maternal mortality, and here, with so many medical folks in the room, I expect I will know less about that than many people here, but I'm sure together we'll be able to fill in any gaps. Why maternal mortality is a human rights issue, and a little bit about what Amnesty International is doing about maternal mortality. So, human rights. And I'm going to start actually by just saying a bit about Amnesty International in particular. Obviously not the only human rights organization, but it's an important one. It's founded by this guy, Peter Benenson, in 1961. So the story goes, he was reading a newspaper one day and heard and read a story about two Portuguese students who raised their glass to freedom. This was under the Salazar dictatorship, and they were imprisoned for it. And he found that so outrageous, he was moved to organize what he called an appeal for amnesty, solicit letters from people around the world writing directly to the Portuguese government and other governments who were holding political prisoners to demand that these people be freed. And that was the start. To this day, traditionally, at amnesty events and that kind of thing, if we're toasting, you're supposed to say "to freedom," and some people think it's cheesy, but I always find it very moving. The history of Amnesty International. So, what we're probably best known for is our work on prisoners of conscience. But you know, when you work on political prisoners, you start to realize that things are being done to those prisoners in prison. So they're being tortured. or they're not even getting to prison. They're being disappeared before they can before they're put in prison. The death penalty is something else that we started working on in the 70s. That was a very controversial move at the time. And more recently, in the last decade or so, we've done a fair amount of work on violence against women. So this gives you a sense of the range of issues that traditionally we've worked on. Where are we now? So biggest membership-based human rights organization, 2.2 million members in 150 countries around the world. We're organized into national sections. So I work for Amnesty International USA. There are 80 organizations like that. And here, I won't read them all, but those are the current campaigns that AIUSA is working on. Maybe any questions even at this early stage? Anybody picking up their membership brochure yet? Okay, we'll get you there.
Only if you can get the ones in Cuba out, then I'll make sure a lot of them will be signed.
Okay.
Where does violence against women fit in under what you do in USA?
So that's a campaign that we launched in the early 2000s, and it was always meant to be a time-limited campaign. Obviously not that the issue has gone away, but we felt that Amnesty International could best help by lending its support for a certain amount of time, and then letting all the other organizations that have been doing work on that take it from there. But there are certainly links between violence against women and maternal mortality. They have the same traditional color, white, actually. Okay. So this is a fly. So this is Tenjiwe Makaris, the field organizer for this region. I was hoping she might be able to be here today, but she wasn't. And this is it's a postcard for our annual general meeting, which is coming up in New Orleans. This is one of our slogans: all rights for all people. So what I want to talk about right now is all rights. What does that mean? That is, the traditionally human rights organizations, human rights work is most associated with civil and political rights, right? So freedom of opinion and expression. These are excerpts from the Universal Declaration of Human Rights. Freedom from torture, fair trials, that kind of thing. But that's about half of the UDHR. And there's another half that has to do with economic and social rights. So the right to education, for example, or the right to a standard of living adequate for health and well-being, including all these things. And the words I want to point you to right now are medical care. So this is Article 25 of the UDHR. This is kind of the root of the right to health in the human rights framework. But there are lots of other places that you see kind of key articulations of the right to health. Here's Franklin Roosevelt from the 1944 State of the Union address, the so-called Second Bill of Rights address. We've accepted a Second Bill of Rights under which a new basis of security and prosperity can be established. Among these rights are the right to adequate medical care and the opportunity to achieve and enjoy good health. Here's the World Health Organization Constitution. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic, or social condition. And here, well, you all know who said this, but Barack Obama in the second debate against John McCain in 2008 said, I think healthcare should be a right for every American. So you see articulations of the right to health, down through the decades, going all the way back to the 40s and earlier. If anybody's really interested in this aspect of things, a kind of technical aspect of the right to health, the first place to look is something called General Comment 14. This body, the Committee on Economic, Social, and Cultural Rights, is the body at the United Nations that's first and foremost charged with overseeing economic and social rights. And periodically they issue authoritative comments that kind of give guidance to governments and other actors on human rights issues. General Comment 14 is from 2000, and it spells out some of the basics of the right to health, and it's now become standard in the field. So a couple of things just to point out about it before you all rush off and read it cover to cover. For one thing, the right to health is about more than just health care, although that's about half of it. The other half is the underlying determinants of health, right? So a healthy environment, a healthy workplace, nutrition, water. Both healthcare and the underlying determinants of health should fit what's called the AAAQ framework. So they should be available. There has to be enough of them, facilities, workers, et cetera. They have to be accessible, right? So, and that means a few different things. There can't be discrimination in access to healthcare or to clean drinking water or whatever it is. They have to be just physically accessible. They have to be affordable, and people have to know about them, which is sometimes more trickier than it seems at first. They have to be acceptable, so especially in kind of multicultural contexts this comes into play, and they have to be of good quality. The right to health is not a right to be healthy. I think of it as the right to the opportunity to be healthy, right? So healthcare, the underlying determinants of health, these are, this is kind of the framework within which a person is or isn't healthy. But if there are huge discrepancies in access to healthcare, to the underlying determinants, then that needs to be fixed in human rights terms. And who has the right to health? Everyone is the answer to that question, regardless of who you are, where you come from, what country you live in, et cetera. And government is kind of ultimately responsible for ensuring the right to health. It doesn't have to provide health care, it doesn't have to, but it does have to make sure that the healthcare system is working for everyone within its borders. It has to make sure that workplaces are healthy, so on and so forth. Questions at this point? All crystal clear? You've all, yeah, please.
I don't want to disturb you too much.
No.
Who would be against this kind of idea?
Well, thoughts? who would be against? Who could possibly be against the right to health? Yeah, please.
I think you'll probably be those who don't want certain groups of people, accessing that kind of health or accessing that kind of commodity that everybody should have.
This makes a lot of trouble for if marginalized group, if there are particular groups that systematically aren't getting this, health care. This puts pretty stringent demands on government and other actors to fix that problem. So sure, defenders of the status quo, that would be one example.
Does the U.S. government belong to this committee?
The U.S. government is a full participant in, all the human rights I mean, in general, we haven't ratified one of the key treaties that guarantees the right to health. The ESC covenant, that's right. So, you know, the US Senate probably has some misgivings about the right to health. And in fairness to, you know, some of the opponents of the right to health, I think government role in ensuring provision of health care, in ensuring a healthy environment, I think there's a range of opinions on what that role should be. So, you know, a lot of people, at least rhetorically, on the right in this country, for example, will say that this isn't government's business. Functionally, they never really believe that, but you know, rhetorically, you do hear that quite a bit. And anyone else want to chime in on this point?
Well, I'm going to raise an issue that was raised in ratification.
Yep.
And I suspect that some of the misgivings about ratification in the Senate has to do with economics. Beyond government role, what would be the cost to people contributing, business and so on? Yep. There's a reluctance to have the economic costs associated with implementation of these rights be borne by
That's right.
engines of economic growth, so to speak.
That's right. Although, you know, there's a lot of literature that says ensuring that basic health care is provided is a good investment.
But that literature is not read by certain people.
Sure.
To know that it exists.
But yeah, no, absolutely. Cost is another issue. Yeah, in the back. That's right.
Medication would be, they might create more generic brand cuts to their, their licensing.
That's right.
So they may not be too happy with that.
Yeah, no, that's right. And I think, is it the next slide? Yeah, that's an excellent segue into this next slide. So just a little, you know, an example of kind of the right to health in action before we get into maternal mortality, and that's, you know, historically, the right to health isn't that old in terms of people actually using this thing as a tool, but work around HIV/AIDS was one of the first issues that where people really successfully engaged governments using the tools of the right to health. So the Treatment Action Campaign is a group in South Africa. Others probably know, again, more about this than I do. But they, over the course of the last several years, they've successfully pressed government, the South African government, to start providing mother-to-child transmission prevention in public clinics, successfully pressed the government to start providing antiretrovirals through public clinics. And that, and generics are a huge issue there, of course. It involved procurement of, you know, lots of generics and making that available. And the government, South African government, was very reluctant to do that at first. Yeah, please.
Did Brazil have a problem with patents, and they decided to infringe on patents for exporting HIV drugs and maybe a new supply for people?
Yeah, I mean, yeah, you know, this comes up in many different contexts, and especially in these kind of middle-income countries where you have, you know, enough of a critical mass of infrastructure where it makes sense to try to start distributing this stuff, but that's the gap, right? It's cost of the drugs. There's an obvious solution, which is go generic, but there are, you know, all kinds of entrenched interests that are against that. But, you know, if you really believe in, if you're committed to the right to health, this is kind of a no-brainer, right? And that is one of the reasons that this becomes a very challenging perspective, because it is a no-brainer. Yeah, please, in the back.
Well, also, you have this anomaly in South Africa where the nation's president kept insisting for how long that AIDS isn't a disease.
Yeah.
Try that one out for size.
Yeah.
That's South Africa too.
Yeah. No, that's right. I mean, yeah, very irresponsible thing for him to have done for so long. Thankfully, no longer an issue. That particular thing, that is. Okay. Other last thoughts before we get into, yeah, please, before we get into maternal mortality.
I think, in sort of our current stage, we're encountered with the dilemma of trying to mix social justice and market justice. And it seems like those are two extremes, and, it's very hard to sort of put those two ingredients together and see if we can come up with a nice outcome.
Yep.
And so, I mean, those are the those are the underlying terms that where the debate exists. I mean, the U.S. was sort of built under this principle of market justice. You can become the greatest you would want to be, and so when you put healthcare and politics and economics and you sort of put them all together, as we're sort of experiencing right now, it's hard to come up with a compromise.
Yeah.
The social justice, I think, is a word that is starting to emerge in terms of popularity.
Mm-hmm.
When we talk about this.
Mm-hmm. Mm-hmm.
I think social justice is probably the answer, because if you look at it on a global level, not just nationally here, you have so many issues, the economics, the women's issues that are tied into that, women being left behind to run and carry the load of men who have not been able to come through with their farming, and these women are now faced with children who are out there in the streets. So I think really the conversation should be about the determinants and social justice campaign more than anything else, because these women are left behind with children, and how do we take care of them? We have the orphans in Haiti. I mean, it just goes on and on. So I think social justice is really what should prevail in the conversation, and women.
Yep.
Totally.
Yeah. And there are a lot of people who are working to bring kind of the moral and legal rigor of human rights to broader social justice issues. And I think the takeaway, at least just for the moment, is in human rights terms, right, everybody has the right to health. And that's a very demanding standard, and it's something that social justice movements, some of them, are finding very useful. Like it's a sharp tool if you want to use it. All right, maternal mortality. Ready? How are we doing on time? Okay. So what is it? Here's the WHO definition. Maternal death is the death of a woman while pregnant or within 42 days of termination of pregnancy. And I won't read the rest of the jargon, but direct and indirect causes of death are included in the tally, just as long as they're pregnancy related.
What's the magic about 42?
Can any medical folks want to chime in on this one? I mean, yeah, please.
I would just say it's somewhat arbitrary in that there's a recovery period postpartum in a normal pregnancy that is kind of generally taken to be about 6 weeks after the pregnancy. You see the hormonal levels fall back to normal at those times, at that postpartum range. So it's somewhat arbitrary, but they had to choose some kind of cutoff. Yeah. So I think it's mainly related to normal postpartum recovery.
A normal postpartum recovery. That's, other questions? No. All right. So, scope of the crisis, and it's a crisis. 1 woman dies every minute. We've been talking, it's 12:35. 35 women have died since noon, somewhere around the world. That's more than 500,000 deaths every year. You see different proportions, but about 98% of these deaths happen in developing countries. That's the biggest disparity of any of the major global health issues in terms of developed versus developing countries, much more than HIV/AIDS infection rates, for example. It's the leading cause of death of 15 to 19-year-old women and girls in the developing world. And, okay, so here it is, a little chart in relation to a couple of other major global health issues, infant mortality and HIV/AIDS infection rates. So this top line is the change in maternal mortality rates since 2000, well, 2000 to 2007. 3–4% reduction. HIV/AIDS infection rates is the gray line below that. Infant mortality rates is the line before that, or below that. So all of these are very pressing issues, obviously, but maternal mortality is the one that's seen the least progress. And one of the things that makes it so important for us to be turning our attention to. And I guess I'll just point to this little factoid as well, or fact as well, right? The interventions you need to promote maternal health typically involve health systems as a whole, right? So as opposed to something like very targeted HIV/AIDS intervention programs where some people will argue you end up with siloing and there are sort of issues in terms of integration of the health system. Maternal mortality doesn't have that problem. So that's both a feature in that it's a good thing to focus on if you want to strengthen a health system overall. It also means that it's complicated in that a lot of things have to happen, right, to bring these rates down. But it's not rocket science. Here are the causes, leading causes of maternal death. And this is about 4/5 of all maternal deaths. This is around the world. Hemorrhage, infection, hypertensive disorders, that is eclampsia and preeclampsia, obstructed labor, and medical consequences from unsafe abortions.
Is that in order?
Yes. Yeah. I don't know the exact percentages. So here's a quote that keeps us going. A past president of the International OB/GYN Federation, a man named Mahmoud Fatala, said, women are not dying because of diseases we can't treat. They're dying because societies have yet to make the decision that their lives are worth saving. And this quote sums up a lot of what makes maternal mortality such an urgent human rights issue. That is, I date a doctor, but I'm not one. We don't have to be medical experts to recognize the urgency of the issue and to recommend particular things that can be done. That is, there's a lot that can be done within the limits of existing medicine.
I think it could also be said that from that extension comes the economics, because globally women carry the economics of a great portion of the economic world is carried by women in all areas. So I think also when you bring that healthy issue, you bring an economic independence, which are a duality really. So I think it's an extension of it that needs to be acknowledged.
Yep, and they're 70% of the women or of the world's poor. Yeah, no doubt.
Which also means that there's another extension of the political, because of the political impoverishment, the absence of representative power to make decisions about economics.
That's right.
And where resources are allocated, you've got the disparities manifesting themselves.
That's right. That's right. Yeah, in the back.
Just wondering, sort of, what the percentage of that list that you have there was goes everything to like cultural practices like female mutilation and those types of things. Is there a high relationship?
That's a contributor. Yeah, that's a contributor.
Major contributor.
I don't have that number off the top of my head, but it is a contributor. That is.
That's another barrier that you have to hurdle. How to sort of
That's right. That's right. Or to be rigorous about it, it's at least correlated, right? FGM is correlated with higher rates of maternal death. So at the very least, it's correlated with other underlying causes of women being left to die in pregnancy and childbirth. All right. Here's so a little technical detail for those of you who are interested in this kind of thing. This is sort of standard as an explanation of thinking about why women are dying in childbirth. It's called the 3 delays model. Those delays are deciding to seek appropriate medical help for an obstetric emergency, delay in reaching an appropriate obstetric facility, and third, receiving adequate care when a facility is reached. It seems very basic, but that ends up being very useful actually in analyzing a health system and figuring out exactly what's going wrong and at what stages. Over the past several years, the maternal health community has come to consensus on what you hear referred to as the core 4, and here they are in order. Family planning and other reproductive health services, skilled care during pregnancy and childbirth, that is, an attendant who can handle a pregnancy that doesn't run into complications, and then emergency care along with a way to get a woman to emergency care when that's needed, and finally, immediate postnatal care. So a majority of deaths actually happen in that postpartum period between birth and 42 days. Questions? No? All right. So what's being done? This is just a little bit about the kind of institutional history of groups working around this issue, trying to raise it to prominence, make people recognize it as an issue. The safe motherhood movement, one of the key dates was 1987 with a conference in Nairobi, which launched something called the Safe Motherhood Initiative. In the several years after that, there were safe motherhood conferences in every region of the world leading up to Beijing, the big conference, which the 15th anniversary of which is being marked as we speak at the United Nations.
Excuse me.
Yep.
1994 was the Cairo conference, Population and Development.
Was Beijing 95?
Yeah.
Okay, that's my mistake. I'll fix that.
Thank you.
Before I give you the PowerPoint. And one of the real wins, though, was all of this kind of raising the prominence of the issue enough that by the time you hit 2000 with the Millennium Summit, with world governments deciding what the key development goals would be, maternal health was included as one of them. Here they are. I'm sure folks have seen these. Number 5 is the one we're concerned with here. And it's the one that's seen the least progress, again, right? So the goal is reduction of the maternal mortality ratio by 75% from 1990 to 2015. What you'd need is 5.5% reduction on a year after year basis, and what we've actually seen is less than 1%. So another way of saying a lot more needs to be done. Some of the other organizations that are working on this stuff, CARE, a group called the White Ribbon Alliance, Family Care International, Women Deliver, and lots of other groups doing very important work. It really is an issue that's turning the corner in terms of public attention, political will.
Is there a sense, Jason, as to what might be done differently to ensure that the rate of progress is accelerated?
That's a big question. I mean, and things have to change at several levels. Starting at the top, right? So rich country governments putting their money where their mouth increasingly is, right? But also people have to start really recognizing it as an issue that deserves its own attention, its own funding streams, potentially its own international financing mechanisms. So some people, like Ann Stars, the head of Family Care International, for example, will argue that the Global Fund for HIV/AIDS, tuberculosis, and malaria should be expanded to include all of the Health Millennium Development Goals. So there is that very high level set of issues that need to be dealt with. Political and financial commitment from rich governments, potentially new international mechanisms for funding these kinds of interventions, but also continued work at the national level. Maternal health is a Millennium Development Goal, but that doesn't mean that everyone's prioritizing it. So, I mean, and it goes all the way down to the level of, as we will say, as we'll get to in a minute, the rights holder, right? Women have to be empowered to claim their right to maternal health. That means information, that means education, that means all kinds of things. Yeah, please. Yep.
Yeah, I'm sorry I came in after you started, so maybe this was addressed initially. But to what degree do you see the growing interest in the United States in home birthing as something that kind of pulls against this discussion, because it's sort of a feeling, especially in the West, in the developing world, that pregnancy and childbirth is so natural and normal that it should kind of be removed in a way from a hospital setting and from professional care, especially doctors, with the stress on home birthing.
Yeah.
That kind of pulls attention away from the very real dangers that can face women in childbirth.
Yeah. I mean, the range, the range of kinds of birth that home birth advocates will push for in this country, that's, they can do that because for many people in this country, there's certainly, good emergency care available if needed, and many people are able to, many people are able to access it without much of a problem, right? So, but, the sort of medicalization of birth and that kind of thing in developed countries like this one, like Brazil, which has seen C-section rates shoot way up. That's it's interesting. It's interesting that that's happening at the same time, as maternal mortality rates staying so stagnant. I mean, just to reach for an analogy here, there's an epidemic of obesity at the same time there's a global hunger epidemic, right? So I mean, so birth is not the only place where you see this kind of bipolar problem. Yeah, please.
It's ironic that in this country, some cite the increased incidence of cesarean section as contributing to the non-improvement in maternal mortality. So it may be different here than in other countries. It may be overtreatment here resulting in problems, whereas in other countries,
that's right.
It's opposite.
That's right.
I'm sorry.
Yeah, please.
There are plenty of other Western developed countries where midwifery,
that's right,
what's called the home birth movement,
that's right,
is done without,
that's right,
under controlled conditions, and these countries have very high birth rates.
Yes, yeah, that's right.
Or a lack of mortality.
Yeah,
sorry.
Yeah. Just one quick thing, and then I'll get to you. And that's the place where the safest country in the world to give birth is Ireland. These numbers are a little bit under review, but it's roughly 10 times. It's roughly 10 times safer to give birth in Ireland than it is in the United States.
Yeah, our infant mortality is horrible here, absolutely. But I think we need to look at the determinants, because birthing is such a culturally driven kind of situation.
Yeah.
And it runs such a spectrum that I think to focus just on the birthing, in the home or whatever, that seems a very myopic view, because you have to incorporate all of the other issues that come to a healthy mother and child.
Yep.
And we really can do that cultural piece along with the health of the baby.
Yep.
If we have the proper health access,
Yep.
disparity,
Yep. No, that's
nutrition,
right.
all of those things.
That's right. That's right.
Economics.
Yeah. But just to finish the Ireland point, I mean, it's one of the very striking things about the Irish maternity care system, as I understand it, is just how non-interventionist it is. I mean, so women going into hospital, like, people would throw up, in this country, they'd throw up their hands and say, that really scares me. But their outcomes are much better than ours.
It has nothing to do with just luck. It's not just luck.
It's the luck of the island.
What's the process here?
Luck. I mean, you know, maybe some of the doctors in the house can speak to the role of luck in health outcomes.
I'd just like to add one thing, and I agree that this should be a comprehensive sort of process. One thing is that about half of our pregnancies in this country are unintentional.
Yep.
And so that, you know, automatically puts people a little bit behind the 8 ball.
Yep.
And in the places where birthing takes place in, say, rural areas or at home, it's not those that are the problem. The problem is when you run into trouble and then access to somebody who can intervene.
Right.
And so that's an issue of those are some system type issues.
Yep.
That probably have to be addressed before you can get some real improvement.
Yeah.
Teen
That's.
pregnancy. I mean, teen pregnancy is out of control.
Yeah.
So it's, you know.
Yeah. I mean, but it is, you know, it is striking how relevant this is in some ways to this country, right? So family planning, right? Access to emergency care, and availability in rural and inner city areas.
Nurse practitioner development, huge, and making them go where they should be going and not in NYU.
I mean, health work.
Exactly right.
Yeah, no, I mean, health workforce is a huge issue in this area in general. Okay, ready for maternal mortality and human rights? All right. So, anybody know who Mary Robinson is? Is this a name that rings bells?
She was president of Ireland.
She was, in fact. And this is one of her key issues. And then she was High Commissioner for Human Rights for the UN. And now runs a group called Realizing Rights, which works on the full range of human rights, but especially economic and social rights. And maternal mortality is one of the things that she's most passionate about. At a conference a few years ago in London, she said, the time has come to treat preventable maternal mortality and morbidity as a human rights violation no less than torture, disappearances, arbitrary detention, and prisoners of conscience. The highest body, human rights body at the United Nations last summer passed a resolution on maternal mortality and human rights, which is a big step for those of us who care about the intersection of these things. So, as I said, things are moving. So so we've talked about the right to health, we've talked about maternal mortality. There are a lot of things we could say about a human rights approach to these issues, but I'll just highlight 3. Attention to underlying determinants, universality, that is inclusion of all women, and accountability for governments and other actors. So Mahmoud Fatala, who we saw before, wrote an article in 1987 called The Long Road to Maternal Death, which really spells out the underlying determinants that are at play here. So obviously, poor and inaccessible health care, but also lack of education for girls, early marriage, lack of family planning, poor nutrition, and low status in general. The an advantage of the human rights approach, as we saw with, what's entailed in the right to health, is this stuff is all built in, right? It's not, healthcare is crucially important, but it's not all there is. All of this stuff you have to pay attention to if you're going to take the right to health seriously. Okay, inclusion of all women. So the Millennium Development Goals they really encapsulate a lot of thinking in the development world. And one of the very striking things about them is they're all about aggregate data. So, you're looking to cut maternal mortality ratios for a whole population. Now, if a government has limited money and it's under pressure to perform on that measure, one way that you do that, a corner that you cut, is you prioritize the most cost-effective interventions, which often means leaving big chunks of the population behind. Something else that's built into the human rights approach says, right, everybody is a rights holder. Right? Everyone has the right to health. And in fact, the most marginalized populations can't be left behind. And, there has to be progress for everyone. So that's an important contribution of a human rights approach to this issue, which otherwise might perpetuate the marginalization of particular groups of women. And finally, accountability for governments and other actors that have obligations, again, for ensuring that a healthcare system is working, for ensuring that the underlying determinants of health are in place. So there's a need to hold governments to their obligations, and in a developing country setting, organizations that are doing service provision, other kinds of development organizations are often, they need to play nice with governments for various reasons. Human rights organizations can be a little more rough and tumble, right? I mean, they can be a little more critical, and sometimes that's necessary. So in Sierra Leone, for example, which we'll talk about in a minute, our campaigners have felt that that's our biggest value added. I mean, you have lots of organizations working on this issue on the ground there, but so many of them have to mute their criticisms of the government, and we're under no particular constraints as far as that goes.
Sorry, you say you are not under any constraints?
Right. I mean, Amnesty International has always been independent of any and all governments, and those are the people that we criticize the most. We criticize corporations too.
Right, but if your workers are in country and they criticize the government openly there, are they at risk?
Yeah, it can be a delicate balance. I think.
Specific question because I work a lot in Sierra Leone. And
Uh-huh.
I know the atmosphere and the environment there. Many people are afraid to just talk politically.
Yeah. An advantage of the Amnesty International brand is it brings a lot of attention. For any kind of political dissidents around the world, they always welcome the attention of Amnesty International because it protects them. So that applies to workers in country as well. I work for AI USA. There is an AI Sierra Leone that's leading the work that we'll talk about in just a minute. I have not heard of any threats to their well-being as a result of engaging in this work. Yeah, please.
I wanted to know how often are these governmental agencies monitored, and if they fail to do what they're supposed to do, are there consequences?
Yeah. You know, I guess it depends on what you mean by consequences.
Is funding taken away, or
yeah.
You know, I know you can't replace them.
Yep. I mean, so the traditional strength of human rights organizations is what's sometimes called naming and shaming, right? So pointing out obligations. If governments are failing to fulfill those obligations, then calling them out on it. And that has a certain, you know, that's a tool. And that's a certain kind of pressure that leads them to change the way they act. We don't, you know, we don't take funding away. But the kind of overall environment around, you know, monitoring, attention to these issues, it definitely changes the way that, that governments allocate resources within their budget and that kind of thing. Monitoring, review of deaths, counting deaths, I mean, that's a huge problem. All these numbers we've been talking about, they're kind of the best guess of the maternal health community, but to be honest, you know, they could be way off in any given place because, in large part because this isn't yet fully recognized as an issue in its own right, so not everybody tracks it as much as they should. Other questions about this kind of general value of a human rights approach stuff before we get into Sierra Leone in particular? And then I think we're pretty much in the clear after that. Yeah? Okay. So I had a prop. Where's my prop? There's my prop. Thanks. This report came out last September. We launched it in country. And followed that with a tour around the country from Freetown to McKinney to, I forget the other stops on the tour. I'm sure you know the country much better than I do. But the report outlines a number of barriers to women accessing the maternal health care that they need. Cost is the one that we focus on the most. That is financial accessibility in right to health terms. And we should be clear, Sierra Leone is one of the most dangerous places in the world to give birth, along with Niger and Afghanistan. Again, these numbers are contested, but something like 1 in every 8 women lifetime will pass away in pregnancy or childbirth in Sierra Leone. One of the issues, so money is an issue in a bunch of different ways in the health system, but where it manifests itself most immediately as a barrier is women going into health facilities, even in emergency situations, and being asked to pay out of pocket for services that are supposed to be free. And one of the things that's contributing to that is the failure of the government to pay the health workers that it employs. So this story, and some of you have a flyer in front of you about Mary and Aminata. They're 2 health workers who Amnesty International researchers talked to just about the experiences that they've had, not getting paid, how that forces them into having to charge women for services just to make a living, and what the upshot for Amnesty's purposes is, right, we call the government out on the pledges that it's made, and put pressure on them through traditional things like letter writing, like petitioning, like our colleagues in AI Sierra Leone going and lobbying, and urge them to actually implement the policies that they've promised to put in place.
I think another extension of that is the migration of these people from the nursing perspective, the depletion of the nursing world from these areas, migrating to other areas throughout the globe.
The brain drain.
And leaving these people to really very detrimental conditions as a result of it. And so that whole social justice point of view in terms of hiring and movement and migration of nursing, at least I can speak of, is another big issue.
Yep. Yeah, absolutely. And you know, the Sierra Leonean health system is so under-resourced. I mean, maybe doctor, you can speak to this even more, but you know, very few doctors, very few health workers, very substandard facilities, and it's leading, as you can see in the numbers, it's a direct contributor to Sierra Leone being an incredibly dangerous place to give birth. So what are we? So what are we doing? I mean, again, it's the basic thing that we're doing is very traditional human rights stuff, right? Identifying an obligation, calling the government out on failing to meet that obligation, and putting pressure on the government to fulfill that obligation in various ways. Like, if you want, you picking up this flyer and writing a letter and mailing it, you know, directly to the president or the health minister or a number of the other folks who we're targeting. I'll mention a couple of the other reports that have come out recently. Burkina Faso is the most recent report that we released. That was it's March already. That was 2 months ago. And there we did, so financial barriers are a major problem here as well. We did have some a big success kind of at the end of the caravan throughout the country. A delegation from Amnesty International met with the president who pledged to lift all financial barriers to emergency obstetric care and family planning in particular. So again, now it's just a question of watching the implementation of that, but that was a big win. Peru is another place that we've been working on. Here, the issues are pretty different than they are in Burkina Faso or Sierra Leone. It's much more an issue of equity within the healthcare system. So Peru doesn't need outside help to fix the problems that it has, you know, especially in rural areas, especially in indigenous areas. It's just a question of representation or lack of representation of those women in the political process. These are some upcoming things. Put on your calendar. But I think I'll leave it there. Questions about any of that last section or anything at all, really? Yeah, please. Sorry, Dean?
Thanks, Jason. I mean, this is really thought-provoking. And hopefully we'll have some follow-up conversations on campus. Well, one of my questions is, how well do we understand of the almost 500,000 women around the world who are dying every year? How well do we understand how that breaks up in terms of the number that are in rural areas, the number that are in war-strewn countries, the numbers that are the result of rape, the numbers that are a result of prostitution? I feel like there are some elephants in the room that we're not talking about. And you know, I just wonder how much we really understand of, you know, there's a certain agency that women have over this as well.
Sure.
And if a woman is raped, or if a woman is pregnant because of prostitution and aborts in a rural area where there is no access to medical care, I'm just wondering how well do we understand the full complexity and profile of the women who are dying Because I feel like if we don't really understand that profile, then are we going at these interventions appropriately? Like what aspects could social work play, and what aspects can, you know, psychologists play in this, and
yeah.
you know, where is some of that?
Yeah. So the answer to the question, how well do we understand the issue, is not well enough, and in part because of just, you know, basic failures of data collection and review at national levels. So that absolutely has to happen, and that in fact is something that a human rights approach will emphasize, is just getting clear on the problem, basic accountability. You know, for every death counts, as we say, so count every death, right? But I would argue that that change can happen, and it has to happen at the same time as interventions at other levels. I mean, we know enough to know that, you know, we need more family planning around the world. We know enough to know that there are huge chunks of many developing countries where there's no accessible emergency obstetric care, and that has to change. So, for example, there's no doubt that change has to happen at many levels, but that definitely includes that very basic top level of understanding the problem better. Yeah, please.
Different sort of a question. How does an organization like, how does Amnesty International decide where to invest your energy? And the thought I just had, I mean, how did you get to Burkina Faso and Peru? I'm just fascinated by that. How did you make that kind of decision where you're going to put your energy?
Yeah. One of the things we need to do this work right is a strong presence in country. We identified places where the problem is particularly bad, like Sierra Leone or Burkina Faso, or where the problem is very bad and much worse than it should be, like Peru or the United States. And those are places where there's an Amnesty International section. So there's an AI Burkina Faso, there's an AI Sierra Leone, there's an AI Peru, and they're leading this work on the ground. I mean, they're lobbying the governments. They're doing things like this, talking to folks like you. So that's a key strength, our presence in those countries when we're deciding exactly where we should work. So those are a couple of key factors, right? How bad the problem is relative to, you know, the socioeconomic condition of a country, our strength in the country, but then also, you know, the amount of attention that the issue has gotten from the human rights community, from the rest of the NGO community. I mean, we're all in this together, and we're trying to make sure that we're adding value when we invest in the research and so on that it takes.
Where can you have the most value added? You know, where's a country that has better infrastructure?
Yep.
I have a friend who's the director of economic plan for Tanzania.
Yep.
And he spent 10 years improving infrastructure.
Yep.
Admittedly.
Yep.
So there might be places where your value added would be better because you got more to work with.
Yep. No, absolutely. You know, but I think Peru actually is a good example of that, right? You know, it's an art, not a science, as they say, picking these kinds of projects, and there are a lot of factors that go into them.
I think the issue too is that it's so universal, and there are so many pockets of unknowns, because even the word prostitution has to be looked at with different glasses, because is it prostitution or is it trafficking? And I think the concept too is, how are we looking at this? From a promotion, primary, secondary, tertiary level, what level are we looking at? Because this is tertiary. But can we do something on a more promotional primary point of view?
Yep.
And so many pockets, it's so overwhelming with so many determinants. It's, anything you do will help. It's really the bottom line, I think.
there's a lot of work to be done on the issue. There's no question about it. Yeah, please.
Yeah, it's a human rights issue, of course, as you're saying, but also, as my colleague was pointing to before, it impacts on economic development because of women's role in the economy, especially, well, really throughout the world. And also, though, when you have the loss of a woman's life, you're losing not just her life, but you're losing her reproductive capacity. And it affects population levels in future generations. So that's something that we have to be cognizant of. The other thing I wanted to say is I think outside certain professional community, there's really a lack of awareness of this and a lack of understanding of the seriousness of it. I teach history, and actually today when I'm talking about the Middle Ages, I'm talking about maternal mortality in the Middle Ages. And the reaction from the students is they don't understand why women would die in childbirth or soon after childbirth. I mean, they go, well, pregnancy, it's a normal, it's a natural thing, it's a healthy thing. And that's the general, I think, perception. And it's a misperception among the lay public, which is very widespread.
Yeah. Yeah. I mean, so there's a scholar of this stuff, a woman named Alicia Yameen, who's at Harvard at the moment, who's done a lot of work on maternal mortality and human rights. She thinks the single biggest contribution that a human rights approach can make to fighting maternal mortality is what she calls denaturing it, right? So making people recognize that, you know, rates of maternal death are the result of human decisions, like institutions at a national and international level that humans, right, run and can change if they have the will to. But yeah, there's it's striking how attitudes about this issue change from place to place and over time, right? So there's a story of our Secretary General was in Sierra Leone last September and met someone, a woman who had had a healthy pregnancy, as it turns out, but when she got pregnant, all of her family came from across the country to come visit her because it's such Russian roulette. They weren't sure whether or not she would make it, right? So and that seemed like something that was happening quite commonly. So, you know, but that's something that has to change if we're going to make progress on this issue. I mean, that can't be seen as natural. Yeah, please.
As we talked about this, I remember many years ago in the early 90s, I had a friend. I was at the Asian refugee early babies, and 4 girls and 1 boy all had episiotomies. I think you know what episiotomy is. And, well, I don't know much about it, but I thought it was bizarre.
Yep.
And the only thing I thought to myself, when I spoke to them, they were glad to have it because it made the birthing process quite quick.
Yep.
But it's high risk.
Yep.
Well, not high risk, but it's certainly higher risk than natural childbirth. And I thought it was interesting that they weren't put in the system. And I thought to myself, I thought there was a correlation, and I'd asked them, but they were just glad it was over. But later on, many years, I had read in here in school that there was a study being done that with lower income people, there are these rushed deliveries. And of course, you know, an open incision is a place for infection, particularly in that area. And there were
it's major surgery. Yeah, right. I mean, that's something else about the medicalization of birth. This won't be news to anyone in this room, but you know, C-section is major surgery. It's not something to snap your fingers and it's over, right? So.
I think just to speak to that quickly, you know, even within the medical community, it's not a perfect process, and so sometimes there's some stylistic procedures emerge, and then actually that particular process is falling out of favor. Now, episiotomy is basically just a cut to in the final moments of the delivery to try and allow the baby more room to get out. And it's now found to be largely unnecessary. But physicians previously thought that it added ease to the birth.
Yep. Yep.
Yes. So luckily, we're learning as we go along
Right.
as well.
Right. Yeah, please.
When someone was discussing, I guess it was Dr. Fishman, about lay people and not being aware, I mean, I think it's just amazing, even if you drive, say, in a certain area around here, like when I had students at clinical at New York Hospital, Queens, you drive from one area and then you're in almost another country, it seems like. And the students have pointed out, too, in the clinical I'm in now, I have a student, my mom was forced to have 16 kids because my father, culturally, we didn't believe in birth control, and she talked about how her mother secretly got an IUD and the father found out. So I think it's this kind of thing. I'm just disappointed that I always want to bring the students in, because when we drive around and we do we do windshield surveys, we do different things, we find out what's going on in areas. In the area where I live, 5 minutes away, people don't have access to things that people that live in these, ivory towers or whatever have. And I think people, a lot of them, don't really want to know. So I think the key thing is education. And we really need to educate our children, people that are here,
Yep.
so that they can know, because they'll pass the word on to other people.
Yeah. Yeah, and certainly in this country, there's a lot of rhetoric that blocks that kind of, right? America has the best healthcare system in the world, right?
Yes.
Depends on who you are.
Right, exactly.
So education is exactly why we're here and why we're doing this.
Exactly.
And I'm going to give this a minute to present. So Jason, thank you so much. And we have a certain tradition here. So
Yeah, so I think this has been a tradition with most of the lectures here at York, but I was luckily the first recipient for the Global Health lecture, and so I've been given the honor of presenting a copy of the poster for this second in our series to Mr. Huff for his great presentation to us on.
Thanks very much. Thank you so much.
Okay, and thank you all. Sure. Please stay for pizza and fruit and refreshments.
Yes. Okay, thank you.
Thank you.
Good job.
Thanks, everyone.